And then on September 17th at 3:30 p.m., a pediatric colleague of mine was seeing her next patient. It was a father who came in with a newborn. He placed the newborn on the scale, and then his pager went off. We looked up at his pager, and there was a message. The message was quite small, so he had to hold it up to his eyes, and it instructed him to press a button. So now with the pager very close to his eyes and 2 hands on the pager, he triggered the detonation, and it exploded. So he had enucleated eye globe, amputated hands, digits. Luckily, my friend and the newborn had minor injuries, but that was the hybrid warfare that was before us. It was the use of explosives placed in personal devices that detonated simultaneously in the thousands across the country. And within 30 minutes, those patients started arriving to our ED, one after the other. The first patient arrived at 3:58. By 4:02, we activated the plan once we realized that this was mass scale, still trying to figure out what exactly happened. And we did what we usually do, the traditional measures of those 15 minutes, security, lockdown, surge area expansion, reinforcements, registration processes for mass casualty, disaster cards came in. But it was very clear early on that this was a very different injury pattern than what we were used to. So usually, what percentage of mass casualty are Greens? 50 to 80% are usually Greens, and that is what the majority of our surge areas accommodate. In this case, we had 182 patients during the activation, and the majority were yellow. 66% were yellow patients. Only 12% red, no deceased. So the majority were complex patients that needed to be seen, most likely needed to be admitted, could not use the surge areas that we traditionally had. The other thing about this is these are people whose hands and eyes were involved, injured, not their legs. So the speed at which people were coming into the ED was quite fast. And in fact, in the first 2 hours, we saw 80% of the patients. So that's 145 patients in 2 hours that walked into our 41-bed ED. So with surge capacity, we could scale up to around, double that. But then what do you do with the rest so that you are not overwhelmed and you still have that control that you need within chaos? And this is when it became very clear that the answer was in that planning that we had of shifting patients early to the inpatient floor. So using the modified care flight triage system that we always use to triage patients into reds, the complex yellows, the walk-in wounded greens, black deceased, that was the initial triage at the door. And then the yellows that went into the yellow areas, then there was a secondary triage that we had planned on to be done by emergency physicians of triaging to who could safely go up to the floor. There are no validated triage tools for this, but we decided that anything that had no torso or abdominal injuries and looked clinically on assessment, physical assessment, that they were stable, that was the decision to send patients up. And that's what we did, shifting around 25% of those yellows to the inpatient floors in the first 20 minutes of care, opening up capacity for the other patients that were coming in. So the second challenge with this hybrid warfare method is imaging. So a lot of these patients had head injuries, and many had pelvic abdominal injuries because those pagers that didn't detonate on trigger actually detonated by time. So those who kept the pager at their waistband ended up with abdominal injuries. So those were the two types of injuries that needed imaging. And even though we had learned from August 4th and from all the literature that CT and imaging remains the biggest bottleneck in MCIs. So we had instructed all of our physicians, minimize imaging, do not do unnecessary imaging, and yet we were stuck with 59 CTs within the first 3 hours. So a queue formed, and to that, what we did on site is really assign an EM physician with a radiologist to do secondary triage and prioritize those patients. We used POCUS, even though the WHO and their mass casualty trainings do not recommend POCUS for care in mass casualties, but we felt it was useful for those patients with abdominal injuries to decide, do they need the CT now or can they wait a couple of hours and can we get other priorities through? But what is clear is that in our literature, there is a big gap here. We do not have minimum standards of radiologic imaging guidelines for MCI care. And this is something that we need to address collectively. The third challenge is surgical prioritization. So we had 142 out of the 182 patients who required admission. And those who required admission needed some sort of surgery, whether it was ophthalmologic, whether it's digital or hand surgery. And you have surge areas in the inpatient, you have surge areas in clinics, you have the ED, all channeling patients to the OR, through, of course, the lead surgeon. But there is no way to keep in mind what those prioritizations are. So what ended up happening is many patients went to the OR, and from there either got re-triaged and prioritized to the floor, or delayed surgery for a few hours. And here again, the need for a staging area in the OR for secondary triage of OR cases is something that I think is an important step to do ahead of time, and is actually one of the WHO recommendations, and thinking about reverse flow OR. The biggest challenge of this attack, though, I think it wasn't just at the hospital level, but it was at the health sector level. So 2,323 injured, 2/3 of whom required admission. And we have 150 hospitals. Every single hospital ended up taking in patients that night. And for the next week, many hospitals delayed elective cases and postponed them, and really just to get through the number of ophthalmologic cases that we had. Because this wasn't just about number of surgeries, it was the type of surgeries. So you're looking at a hybrid warfare mechanism that had injuries in specific, very specialized areas, eyes and hands. And even if you had enough ophthalmologists in the country, having the right equipment in the OR for them to be able to run through the OR cases was a big challenge. So it really required an entire country's health sector over a week to get through all the cases that we had. And beyond that, there's the psychological impact of the victims. As you can see, the injuries are very much involve the face. The plastic from the pages with the epithelialized skin leaves these tattoo marks. The enucleated eye lobes is a very common feature, and very, very distinguished and distinguishable, and in fact meant to be so. In an interview by the perpetrators or the planners of this attack, they said that they wanted the patients to remain and feel vulnerable for the rest of their life. So this is a new way, a modern way, a hybrid warfare way of branding the indigenous population. Another question that this attack raises in terms of mass casualty planning. The next day, none of the residents wanted to use their pagers. And rightfully so, but we were left as leadership trying to figure out how do you assess a pager, this isn't our expertise, for whether there was implanted detonation or explosives in it. And then beyond that, as you guys know, with communication systems in disasters, we rely on many different, we rely on conventional pagers, walkie-talkies, by the way, exploded the next day. So walkie-talkies, pagers, Wi-Fi messaging systems. So even with the Wi-Fi messaging systems and our smartphones, those were being today, the experimentation of AI in military and the use of our phones to track through voice recognition, through the messaging that happens through our systems, has been used to identify and kill people, including healthcare workers. So my biggest fear throughout the responses during the two-month war in Lebanon this fall was when I was running to my mass casualty responses to lead those responses, I had this dilemma of I can't leave my phone because that was the forum through which I communicated with my team. But on the way to the hospital, I'm constantly thinking, this is the tracker, this is my tracker. So how do we go about communication in healthcare when this is our new reality? Whether it's pagers, conventional communication systems, or Wi-Fi messaging systems. So that was the hybrid warfare that we faced, one of the hybrid warfares that we faced. But there is another hybrid warfare that is emerging as one of the most powerful warfares being used today in conflict. What is hybrid warfare? It's the use of conventional warfare through non-conventional methods or vehicles to inflict harm and to inflict mass destruction. So what happens when you take bombs, 2,000-pound M84 bombs, and use them around hospitals? There is an excellent article by the Harvard group that looked at geospatial proximity of the craters from these 2,000 bombs in proximity to hospitals. And this was just in the first 6 weeks, so October 7th to November 17th of 2023. 36 hospitals in Gaza, and what they found is that 25% of the hospitals had at least one crater within lethal range, and 83% had craters within infrastructure damage and injury range. So you have the conventional, you have the non-conventional medium, but is it just at the healthcare facility level? What we were seeing is sieges of hospitals that requiring physicians to make a decision of either being imprisoned, abducted, killed, or abandoning their patients. We had children being used as bait for paramedics who were then executed on arrival. And we have the persecution of physicians who refuse to abandon their patients, their detention and torture, 3 now dead in Israeli prisons. This is happening not just in Gaza, it's happening en masse in Gaza, but it happened in the 2 months in Lebanon. 67 hospitals had the similar destruction patterns. Craters and bombings around the hospital, 56 primary care centers, and in just those 2 months, we had 222 healthcare workers killed. In Ukraine, WHO has documented 1,940 attacks on facilities, 200 healthcare workers killed, and hundreds of healthcare workers detained. So, the conventional, the medium, and then the outcome. So what is the destruction? Well, what happens when you have populations that are sieged, no water, displaced, no food, no medicines coming in, en masse, and then you strip them of healthcare? What happens to communicable diseases? What happens to chronic diseases that now cannot seek care, dialysis, diabetes? What ends up happening is well documented at this point. If you look at just life expectancy of people in Gaza, pre-war and war, it's gone from 75% down to 35%, 75 years to 35 years. And if you look at access deaths, so now we're talking about deaths not related to direct trauma. Usually estimated, calculated, either 1 to 3 if you're really using conservative, to 1 to 15. This article in The Lancet in July of 2024, so almost 8 months ago, looked at those numbers and took a very conservative estimation of the indirect deaths. And by those estimates, even then, 8 months ago, it was 9% of the population, 186,000 deaths. So this is how attacks on health have become the most powerful warfare method, the hybrid warfare method that we have. You have chemicals that are exploding or being exploded. You have personal devices that are implanted with explosives, and you have attacks on health. And out of those, the most powerful one is the weaponization of health. So how did we get here? How did we get to a place where personal devices are exploding, which is, by the way, a war crime? UN experts, human rights experts, describe it as a war crime because it violates the humanitarian law by failing to verify each target. You get here within an environment that applauds this type of sabotage. In fact, the New York Times says it's a sophisticated sabotage. Trophies and prizes and gifts are being handed out with a pager in them. It is something that the general overall community is praising instead of condemning. What about healthcare? How did we get here in healthcare? We got here because we are in a society where criticizing attacks on health has become controversial. And where the stewards of health, us, the medical community, have been, for the most part, silent. And I think we all know what the impact of silence is. It is the silence that creates the space for perpetuating atrocities and war crimes. And this is really right here. So it's been 16 years now in Lebanon. Very rewarding years, very fulfilling years. Yes, with smatterings of conflict and crisis. But I can tell you from 16 years that there is a way to face crises and uncertainty. And it's knowing two things about uncertainty, two things that are constant. One is that they will pass, crises will pass. And two is that what will remain is the decisions that we make and we have to live with after the crises. And when I feel that I am powerless facing the overwhelm of the situations or the challenges that I'm in, today I draw my energy, my strength, my courage from the physicians in Gaza who choose not to abandon their patients, even knowing that the risks that they are taking by doing so. And I look a lot, I come back to the statement by Dr. Mahmoud Abu Njayla, who wrote this on one of the whiteboards of Al-Awda Hospital when it was under siege. He says, "Whoever stays until the end will tell the story, we did what we could." This moment will pass too, and may we all get to the other end, knowing that we have done what we can to resist normalizing having to build mass casualty responses to scale, to resist normalizing use of personal devices as weapons, and to stand up against the weaponization of health. Thank you.